Patient is a fit 25 years old male with a 2 cm PUJ calculus, mild hydronephrosis and good functioning kidneys. We perform supine PCNL in Fosman position, which has 3 components: flank free, oblique supine and modified lithotomy. In the pre-op area, 3 lines are drawn. These are the posterior axillary line, 12th rib and the iliac crest. Flank free is achieved by a small bolster placed below the ipsilateral hip as shown by the yellow arrow. Oblique tilt is given by 30 to 45 degrees using a side back support as shown by the red arrow. In modified lithotomy, the ipsilateral leg is extended and kept at a lower level as compared to the contralateral leg. Ureteric catheterization and RGP is done, and the lower posterior calyx is punctured in the marked renal area, staying medial to the posterior axillary line. Following guide wire insertion and tract dilatation, free flow of fluid from the Amplatz sheath is confirmed. Lithotripsy and stone removal is done by the surgeon in a comfortable sitting position. Complete clearance is confirmed. Intrarenal manipulations are feasible in the supine as in the prone. This is the upper calyx, the pelvic-ureteric junction, the middle anterior calyx, and the mid-posterior calyx. The Amplatz sheath is withdrawn, which shows minimal bleeding from the tract as it is absolutely peripheral puncture in line with the infundibulum. The horizontal position of the Amplatz allows gravity-assisted fragment removal and keeps the intrapelvic pressures low. Stent and nephrostomy are placed at the end. The benefits of supine PCNL are apparent. It's a favorable position for anesthesia and allows better airway control and ventilation. This is of utmost importance in obese patients and patients with chronic airway diseases who do not tolerate prone position well. This allows simultaneous PCNL and ureteroscopy, that is ECIRS, which can be done by 2 surgeons, one operating from below and one from above. OT time with respect to position change is saved. Fragments are removed by gravity, thus reducing the time to manually pick up any fragments. Surgeon operates in a comfortable sitting position. Lower intrarenal pressures reduce infective complications, and there is a lower incidence of colonic injuries due to lower incidence of retrorenal colon in supine as contrast from prone position. There are, however, some limitations. One requires a longer tract size, which mandates longer needle and Amplatz sheath. There may be less space for multiple tracts, and there may be some difficulty